Welcome everyone. Happy Thursday the 13th of July and hope you're all well. My name is Fran Platts. Some of you will know you, some of you won't, but it's my pleasure and privilege on behalf of the Nottingham and Nottinghamshire Falls and Physical Activity Community of Practice Project Group to welcome you to our second live webinar. Special thanks in advance to our guest speakers, Jack and Aga, James, Joe and Paula. The focus today is to showcase the great work across our hospitals on how we are making movement a priority. Hospital staff deliver patient care 24/7, 365 days a year, and it is of vital importance that our hospital environments promote physical activity. Today's activity is tomorrow's discharge. Mobility saves lives. And in the great words of Sir David Attenborough, all life on earth depends on the freedom to move. So without further ado and delay, as we have a jam-packed hour for you today, we will share to start with John's story, a story from Sherwood Forest Hospitals. Thank you, everyone.
We're here celebrating National Walking Month, or Walk This May. And to celebrate this month, we are going to hear from our lovely patient, John, who's going to tell you about the importance of staying active in hospital and continuing to walk. And we'll also hear from some healthcare practitioners as well about their role in encouraging activity and being active whilst in hospital. Whilst it's important for our patients to be really, really active, it's important for everyone to be active. And so I'd love to encourage you all throughout National Walking Month to be as active as possible. Get out there and get walking.
Being active and walking whilst in hospital helps patients to keep their strength up, helps people's respiratory function, keeps their breathing good and reduces their risk of chest infections, and it helps them to get better quicker and out of hospital back to their own environment sooner. So I think all of us can encourage patients to get out of bed and walk more. Partly that's through actually getting people up and out of bed and encouraging them on their feet. And it's also challenging why people might be on bed rest, because there's very few reasons that patients really need to be on bed rest in a hospital environment. So watching a patient recover from illness and get their mobility back is really satisfying, because you can see them recover to where they should be, and you can see the fruit of your labours by them getting back to a good, healthy state, back on their feet and back home.
I think the benefits of the patients being active in hospital to the bed. We know that it's longer hospital time. It takes a lot longer to discharge them. It brings more complex issues into discharging. I think they become normalised to being in bed. They've got an increased risk of getting chest infections because the breathing's altered. I know they're ill, but they need to mirror obviously what the home life is to get a quicker transition to home. So if we can keep everything as normal as possible with treating them, then I think that benefits them on discharge. I think staff on the ward to encourage patients to be more active and get out of bed. Once they're over the initial 24 to 48 hours of the illness, then we need to be getting them out as soon as possible, even if it's for meal times. If we educate our staff and tell them why we're doing it, and then they're more likely to carry it out. On the ward, we do PJ paralysis, and that's still ongoing. So every patient's care should be individualised. We obviously need to try and get back to that baseline. So we have care plans that will look at that, and we individualise it to each patient. We don't use it, you lose it.
When we see patients that come in acutely unwell, we get them better, and it's fantastic really to obviously see someone so poorly, and then when they are safe to go home, getting them discharged. So it's really good, it's really fulfilling. So when looking after our patients, if they don't want to get up and get better, obviously we have a lot of encouraging, getting people out of bed, helping with their chest, encouraging their mobility, and obviously the ultimate goal is getting them home safely.
Everything had been going fine. I'd had cancer, I'd had large lymph nodes, and the cancer had gone, the lymph nodes had gone, and then all of a sudden I had a collapse at home one evening, and basically I was unconscious for nearly, 7 hours. Bottom line, I've been here ever since. I mean, without Les, when Les first saw me in here back in the days, I couldn't stand unaided. I couldn't go to the toilet. Well, I'd start from scratch. People like Beverly and Sean, they're diamonds. They really do care. And that makes life an awful lot easier when you're dealing with somebody that cares. I look forward to seeing Les. I do. So she will come on, let's get you up. Let's get off down that corridor a bit. Don't worry, you're not going to fall over. It's a secure arm there all the time. And I know he'll never let me down. Never. He won't never ever let me down. No, none of them will. I've never ever stopped from being a fisherman when I was 7. I had a very sporting background, playing cricket. I'm fortunate, won a lot of money fishing. Won 8,000 quid one day. That was more than a week's wages. I worked virtually all my life in the licensing catering trades. I got married to my wife when I was 27 and I'm 81. And we've never, ever been apart. Yeah, I've got a goal. I have got a goal. Fishing the side of a lake. Yeah, fishing the side of a lake. Which means, therefore, I would be able to have my car back. I'll be able to drive the car. And I'll be able to fish. And I'll be with my friends. I appreciate what you've done for me. I'm going to get back. I'm going to get back to my friends and my previous life. I've said lots of people before. I'm going to get my telegram from the Queen.
So when John come into hospital, he was really poorly, really down. What I wanted to do was get him out of bed, but I had to build him up, get talking to him, get a good morale with him. So every day we used to go in and just do little bits, getting them to the side of the bed to start with. And then we'd try a bit of marching on the spot and try them with the rotunda to start with. And then we moved on to the frame, find out where they worked or what they do, this is what I do, and talk to them and build a bit of trust up with them. You do build a friendship up, and John's a lovely chap. And it is nice when he says, like, you've done well for me and that. It's lovely. Always encourage him and tell them they're doing really well. We're still working with him, but he has got his life back more than before. It was upsetting, and he has been through a lot. They know you've done the best, and it's good from our point of view, physio, but as a hospital, we've all done his best to help him.
Johnny's continuing his recovery at home, spending more time in his garden and with his family, which is great to see. But the reality of his situation remains the same for many of our patients in our hospitals. And so we want to continue to encourage people to get walking and get active throughout National Walking Month and beyond for our patients and our staff and our loved ones.
Excellent, thank you. Okay, so we'll move on now to Jack and Aga from Kingsmill Hospital Orthopaedic team to share their presentation with us around the great work that they're doing on the power of prehab and enhanced recovery. Over to Jack and Aga. Thank you very much.
Hello, everyone. Thank you for joining us today. So my name's Jack. I'm the physio team lead for trauma and orthopaedics at Kingsmill.
Hello, and my name is Aga. I'm team lead for occupational therapy in trauma orthopedics.
So today we're going to talk about enhanced recovery and sort of the protocol that we follow and try to adhere to here, and how that ties into making movement a priority. Next slide, please. So I'm briefly just going to talk about what is enhanced recovery, and many of you may have come across this term before. So there isn't just a set protocol, you can't look it up on the internet and follow instructions. It's very much an idea, and until we come up with ways of incorporating this idea and integrating it within our work, it doesn't happen. So as you can see, it's an evidence-based approach that helps people recover quicker from surgery, and it aims to ensure that patients are, one, as healthy as possible before receiving treatment, that they receive the best possible care during the operation, and that aftercare is as good as it can be. Now, that sounds very simple, and it sounds what you'd want for all of your patients that you see, but until it's actually incorporated, that doesn't happen. So next slide, please. And the reason it doesn't happen is because it requires a huge multidisciplinary buy-in. So it's not just from a therapist perspective. We need buy-in from the nurses, the consultants, everyone involved in that surgery process throughout, anaesthetists, etc. And it should be led from the top. It's ultimately the consultant that agrees to do the elective surgery, and from there it should be trickled down to the rest of the MDT. So we really need that buy-in, and I think as a whole therapists are very well positioned to really promote this strategy. So often it does fall to us to do training with other professions, and really encourage this. From a therapist point of view, it's something that perhaps everyone does without even thinking about it. So, as we've just seen from the video there with Les, we get people out of bed. We're often encouraging them to take fluids on board without even thinking about it. We'll make sure you're drinking lots there, John. We do these things on a very regular basis. Next slide, please.
So our patients come to us, and we usually support them from a more practical point of view. So we ask them to think about how they will manage just everyday activities, after the surgery, to think how they manage them now. And they ask us questions that usually they don't ask the nurses or the consultants, because we seem to be more approachable. So we advise people on how to do the shopping. People sometimes ask us how they will have a shower or a bath after the surgery, how they will manage those daily activities. And we support them before the surgery and during our group, and also during the stay in the hospital and after the surgery. So next slide, please. So our journey with the patient starts at the pre-op. Next slide, please. And our aim for our pre-op, we organize the weekly groups for education sessions for people they prepare for knee or hip replacement. And our aim for the group is to provide advice and support to prepare the patient from a functional perspective. So it's about how they will manage those tasks and activities at home, how to manage pain as well, and to raise awareness of maximizing physical condition before the surgery. We encourage them to be active, to be moving, to be managing those daily activities. So, for example, managing the stairs at home, and to give patients the real life awareness of the consequences of the decision, so positives and negatives. And because sometimes patients are focused on their, the life is going to be much better, but sometimes they don't realize that obviously it's got some burden, the decision they've made. Next slide, please. So during our classes, the main aim is to educate patients on what is going to happen to them, and it is all within the NICE guidelines. And people come to us and they sit down in our group, and we've got a presentation for them, which we are not going to show here. They've got a video as well to watch, and we received really good comments about the videos, because this is on actual ward. We've prepared the video on our wards with the MDT members. So we've got physios, we've got OTs, we've got the nurses on the video as well, and patient can actually see what it's going to look like in real life. We talk about the exercises before the surgery and after. We do mobility assessments as well, and we try to explore what it is the patients might struggle with at home as well. Patients are issued mobility aids as well for home to start practicing before the surgery. We demonstrate and show and talk about the equipment that occupational therapists can provide for the patients. And we talk about, we ask questions about any anxieties, any issues people think they might have after the surgery, and we discuss how we can support them to address those issues. And we also ask people for feedback about the group, what it is they think was good, what it is they feel that might be improved. Next, sorry.
So right from the off, we're prioritizing that movement, and we're setting those expectations with patients that they will be getting up and out of bed. They're expected to do things for themselves, so putting some ownership back onto them to think about their own health and take it into their own hands to a certain extent.
And then we are involved with patients after the surgery. Next slide, please. So it's like Jack mentioned, we encourage that early mobilizations. We make people aware during the group that as soon as the surgery is done, as soon as they recovered from anesthetic, they are going to be moving. The physios will come and they will ask them to mobilize with mobility aids. Occupational therapists will come and try to practice the bed transfers, chair transfers. We also do functional assessments. So if people have any concerns about washing and dressing, meal preparations, we are able to facilitate it on the ward. We also quite heavily involved in encouraging oral input and hydration as well, because we don't want our patients to have IV fluids or any other devices that are not necessary and might restrict that movement. And then we are involved in planning discharge, making sure that our patients are going to be safe at home on discharge, that they will manage as independently as possible.
It's really important to set those expectations so it's not a shock. I often get patients saying, "What do you mean I'm getting out of bed? I've just had major surgery." But we advise them that is advised by all the research and the evidence.
And they react really much better during after the surgery. They know they are waiting for us. They know they need to have pain medication. They just need to be ready for mobility.
Next slide, please. So what is the impact of all of this? Next slide, please. So we're talking about patient outcomes and hospital outcomes. So from a patient perspective, it dramatically reduces length of stay. It reduces post-op complications, so things like blood clots. It gets the digestive system going, so helps to clear that system out, because obviously they're on lots of pain relief, and it helps to reduce respiratory complications as well. It prevents, there's a reduction in delayed discharges due to equipment or care needs, because that's been addressed beforehand. We have improved functional outcomes overall, identifying and addressing those concerns really early to ensure prompt discharge and encouraging independence, which overall can help reduce pressure on social care. And then from a hospital perspective, we're looking at efficient bed flow, because that's nice and smooth and patients aren't staying for longer than they need to. A reduction in resource demand, because they're out of the hospital quicker and it's a safer discharge, and reduced financial burden. Next slide, please. So we've been doing an audit for the last 10 months. You can see in the top right there that the average cost of an elective bed per day is £391. And we've audited the fact that if the patient came to our pre-op class and if they didn't, and then we can see the comparison there between hips and knees. So THR being total hip replacement, the length of stay without the class being 2 days, with the class being 2 days and without the class being 3.1 days. So there's a 1.1 day increase in length of stay. And you can see the same for the total knee replacements there. Next slide, please. And just as an estimate, that is a saving of £44,000 in 10 months. And that just includes bed costs. So it doesn't include the extra costs that would be incurred due to staying in hospital or potential post-op complications and things like that, which can be avoided by mobilising earlier and preparing for that discharge straight from the off at pre-op. Next slide, please. So just to finish off, future thoughts. So at the moment, most prehab is outsourced into the community. So we could utilise that better within outpatient settings. So outpatient settings very much focus on sort of the recovery afterwards rather than the preventative measures. And they're very, very burdened and stressed with lots of patients at the minute. So it's a real difficult area.
And then we were just thinking about it, that many of these surgeries could be prevented, but it would have to start with the primary care. So one of the ideas is having social prescribers, mainly OTs in the GP surgeries, to find activities to make sure the people are mobilizing and are strong enough so they don't get deconditioned whilst they are at home.
And all the evidence points to enhanced recovery and the fact that it works, so it's something that we should be following. Preventative measures are much cheaper than going through the actual surgery themselves, and therefore we could reduce the whole elective orthopaedic burden on the NHS by thinking about this a bit more and trying to promote that mobility as a lifelong thing. Thank you very much.
Thank you.
Wow, thank you, Jack and Aga. That's incredible. Thank you very much for sharing that. So we're going to move swiftly on now to James from Adult Critical Care at Sherwood Forest Hospitals to share with us a wonderful presentation about the work that they're doing there. Over to you, James. Thank you.
Hi all, thank you for having me, and thank you for attending today. I hope you're enjoying it so far. My name is James Thwaites, and I'm a critical care physiotherapist and advanced practitioner, and today we'll be discussing why making movement a priority on critical care is important. Next slide, please. So, to understand why mobilisation is so important on critical care, we first need to understand what happens when patients are critically ill. Next slide, please. This is a picture of a common bed space on intensive care. It looks very busy, I know. When patients are admitted to critical care, it's because one or more of their organs are failing and those organs need some support. This support can be things such as if a patient's renal system is failing or their kidneys aren't working, they may be put on a filter to filter their blood. If a patient's lungs aren't working and they're in respiratory failure, they may be put on mechanical ventilation with a breathing tube down their throat to help with their respiratory system. Or if a patient's cardiovascular system isn't functioning and the patient has critically low blood pressure, they may need to be put on critical care medications such as noradrenaline to pick their blood pressure back up to a normal range. Now, these are just to name a few. To help patients tolerate these interventions, such as mechanical ventilation, they're often put on sedatives to keep them asleep. In some cases, patients are also put on paralysing agents which inhibit all of their body's muscles from working. Unfortunately, the combination of all of these things put together tend to lead to bed rest and immobilization during their stay. Next slide, please. So, to give further perspective, here's a real-life picture of an intensive care unit bed space. Now, we touched on different equipment and medications such as the sedatives that lead to immobilization, but there are many more barriers which contribute to this on intensive care. For example, the patient's perception, so they may feel too fatigued or believe that staying in bed and resting is the best thing for them. I'm sure we all have relatives who sort of have this opinion. And this can encourage immobilization, and it takes a lot of patient education to talk them around. Another barrier can be the environment. So there's very little bed space in intensive care with all of the attachments and machines around. And if we look back to only a year or two ago, some units had 2 patients per bed space back in COVID. So there was no room for chairs, no room for equipment to try and get people out. It made things really, really difficult. Other barriers, so things such as pain, preventing patients getting up and moving, and even things such as workforce culture. So staff can be resistant when looking at new ways of working, especially if it makes things harder. Now, the easiest thing that we could do is leave a patient in bed, but we know that's not good for them, and we're going to talk through why. So the list of barriers really does go on, and there's lots of research around it, but we'll crack on. So next slide, please. So what can all of this bed rest and immobilization lead to? Next slide, please. This leads to muscle wasting, known as atrophy, which occurs early and rapidly in the intensive care setting. Research has shown that a decline of 2 to 4% muscle mass per day occurs in the first week of a patient's stay in intensive care. This atrophy can lead to something that we call intensive care unit acquired weakness, or ICU acquired weakness. And this is a neuromuscular complication associated with patients on the intensive care. It has an incidence of about 40%, meaning 2 in 5 patients who are admitted to critical care will develop this. And ICU-acquired weakness can make simple tasks, such as going from sitting to standing, extremely fatiguing for patients, and can even work them anaerobically, so the body's working without oxygen. This can lead to a vicious cycle, as the more fatigued the patients get, the less they do, and the weaker they get, and so forth. So for patients who develop ICU-acquired weakness, it can take about 18 months to recover, with some patients never regaining their full functional ability. Next slide, please. So ICU-acquired weakness is also associated with many complications, including increased time on a ventilator, increased length of stay on intensive care, as well as the hospital setting as a whole, increased morbidity and mortality, poor functional outcomes, increasing the likelihood of needing community services at discharge, and lastly, all of this leads to an increased cost for the NHS and hospital settings. Next slide, please. So, what can we do as healthcare professionals to help fix this problem? Next slide, please. So, to date, exercise is the only evidence-based intervention to help prevent and treat ICU-acquired weakness. The earlier we get patients up and moving, the better. Even when patients are sedated and ventilated, it's important to reduce down their sedation until they can wake up and then get them up and moving daily. I've included a few pictures here just to show you what this can look like. You can see that all of these patients obviously have a ventilator, and it's to show that this can be done even when patients are critically unwell. Next slide, please. So not all patients are appropriate to do this with. So to help maintain patient safety, it's important that we use an evidence-based safety criteria, such as the one above that I created for my trust and we use on our unit at the moment. Next slide, please. Now, I know I'm fairly limited for time, but as you can see, there are a lot of benefits to early mobilisation in the intensive care unit. Now, all of these are extremely beneficial to the patient. However, I just wanted to touch on the reducing cost point, which I know Jack and Aga obviously went through with orthopaedics as well. As healthcare professionals, we tend to focus so much on patient outcomes, which is fantastic, that we often may overlook some other important organisational benefits to the interventions that we provide. Next slide, please. To demonstrate the importance of this intervention, I wanted to touch on this paper back in 2017. So David McWilliams, who was a consultant physio at Queen's Elizabeth Birmingham, he ran a quality improvement project on implementation of early rehabilitation on intensive care. They hired 2 full-time Band 6 physiotherapies to solely work on getting patients up and moving who are on the ventilator. 292 patients were included in this QI project, and it cost about £75,000 for the 2 physios to be hired for the year. Results found that the early mobilisation group, so the patients that were got up nice and early, had a reduced average hospital length of stay by 5.1 days, a reduced average critical care length of stay by 2.5 days, a reduced average duration of mechanical ventilation by 2.4 days, reduced time to first mobilise by 3 days, an increased level of mobility at the point of critical care discharge, and lastly, a reduced in-hospital mortality rate by 11%. So bearing all of this in mind, over the years period, just have a think in your own heads, how much money do you think this saved the trust by getting patients up and moving nice and early? Next slide, please. £951,200. Now that is crazy. So for a £75,000 investment, that's not a bad take home, that. And I really hope this goes to show the magnitude of how important mobilisation is, even for those who are at their most unwell. So if we can get people up and moving on critical care, I'm sure you can get people up and moving on your wards, no matter how poorly they are. It's a bit of an old school saying, and Fran, I'm going to join you with the puns, but movement really is medicine. And I think you'd really struggle to find a medicine that's as effective as mobilisation. I can't emphasise how important getting patients up is, and and I hope this sort of presentation has shed some light on the benefits that it provides. Next slide, please. And thank you all very much for listening. I really appreciate you all turning up and hope you learnt something. Thank you.
Thank you very much, James. That's just fantastic. Excellent presentation. Really great to hear the amazing work that's happening at Kingsmill and the opportunities, and absolutely movement is medicine. Superb. So we're going to move along now. And next up is Jo from NUH. Over to Jo, please.
Hello. So I'm going to be talking today about some work we did on one of our acute wards. Next slide, please. Cool. So this is a project that we ran on one of our acute wards called F21, which is the alcoholic liver disease ward, and it's part of the Active Hospitals programme. So the Active Hospitals programme is a national pilot scheme, and we were part of the pilot alongside Northumbria Healthcare, North Tees and Hartlepool, and Sheffield Children's NHS Foundation Trusts. We were funded by Public Health England, which is now the Office for Health Improvement and Disparities, Sports England and the National Lottery. And we're building on the work started by Oxford University Hospitals NH Trust that is encapsulated on the Moving Medicine website, which I'm sure a lot of you are familiar with. And OHID have been overseeing the work we've been doing. And part of what we've been doing is this ward work that I'll be talking to you about today. Next slide, please. So F21 was chosen as an Active Hospitals pathway because we had a very engaged consultant, essentially. So the consultant was involved in doing the bid for the pilot. They were very keen to get us working on their pathway, and we ended up working on one of their outpatient pathways as well as their inpatient pathway. And she helped us set up a working party. So we had therapies, consultants, nurses, ward staff, ward manager, and dietitian attending our working party. And we kind of worked together to work out what we wanted to do on the ward, and we started doing all that stuff in August 2022. So it involved us training up ward staff to be physical activity champions. There's a national programme called the Physical Activity Champions Training Programme, or PACC training, again, which I'm sure some of you are familiar with, and we trained all of us, the ward staff, as champions. We introduced a nerve centre assessment. So nerve centre is our digital records system, and we introduced a physical activity assessment, which gets a baseline of how active people are in their daily lives in minutes, and then lets us assess whether patients have been given information about keeping moving and information about how they can do that on the ward. We worked with the patient involvement group to create something called the Keep Moving sheet that I'll show you in a minute. We engaged with some volunteers, and we started measuring hand grip strength. Next slide, please. So the Keep Moving sheet was brought to us by the patient partnership group, and they had developed one side, which you'll see in a minute, which was all about why movement was important. But when they'd gone out to patients to get feedback on it, patients had asked for another side containing bed and chair exercises. Patients were saying, we spend a lot of time in our bed, we spend a lot of time in our chair, and we want to know what we can do to help ourselves while we're doing that. So this is what we look to do. And we look to use some video and some graphics to help improve accessibility. We got the learning disability team to have a look at it and make sure that it was accessible from their point of view as well. So if we could have the next slide, please. So this is the first slide that the PPG had developed. So as you can see, it's got some patient information around why getting up and moving around is important. And the initial feedback they had when they audited this with patients was that patients did not know this information. Patients thought that being in hospital meant bed rest and meant that they were kind of having the need to be in bed, the need to not move around too much. And they were surprised by how beneficial being active could be. So the next slide, please. So this is how we wanted to promote them to be more active. So we worked together with senior physiotherapists and kind of identified a series of exercises that the physiotherapist would be suitable for most medical patients. Obviously not all medical patients, we've got a disclaimer at the top, but they felt that these would be widely useful for patients, and we had videos of physiotherapists doing these exercises there with the QR code. We worked with our comms team to get the graphics sorted. We worked with the learning disability team to get the text sorted, and we launched the sheet on the ward. Next slide, please. Our initial outcomes have been measured using our nerve centre assessment, and we've looked at who has been signposted to be more active. We also looked at patients being sat out for lunch. We've looked at falls, and we're starting to look at the hand grip strength data, which we've been collecting throughout. Next slide, please. So we can see here that initially we didn't have any patients with physical activity being assessed. So over the period, we've kind of got to about a third of patients, but we've had a steady increase since around November, December time in patients who have been having some physical activity assessments completed with them. And this means that they're discussing physical activity, they're talking about why it's important, and they're having a conversation with staff about why they want to keep moving in the hospital. Next slide, please. This is the site. This shows you how many patients have been signposted to be more active, or kind of given access to the keep moving sheet, or given access to physiotherapy exercises on the ward. And again, you can sort of see this steady increase since around November, December time, which we think is probably attributable to a couple of the newer interventions we've used on the ward. Next slide, please. Falls data doesn't show an improvement, but it doesn't show an increase either, so it's kind of fairly steady. The ward leader is a falls lead, so their falls data is extremely good anyway, and their falls are extremely low, but we haven't increased them. Next slide, please. And here you can see that patients sat out for lunch. We've decreased the variance in that, so we haven't got more patients sitting out for lunch, but we've got less variation in how many are spending time in bed for their lunchtime meal, and how many are getting out of bed for the lunchtime meal. Next sheet, please. So what we did in November, December time was start to recruit volunteers to use the Keep Moving sheet with patients to kind of demonstrate what to do and help motivate patients to get engaged. We have engaged with our volunteer team, and we've done some targeted recruitment as well with our local universities. We offer them induction and training, so they get some one-to-one support and some small group training, and then some ongoing competencies on the ward. So we take them, give them some coaching in how to do the exercises. Next slide, please. And between April and July, we increased our numbers to 15. And volunteers delivered 37 contacts and 1,895 minutes of support on the ward. Next slide, please. So our rollout will be across 3 other wards. So you can see our numbers there. So we've had a number of contacts, a number of minutes of support on each ward. On one of our wards, one of our volunteers is now running groups. And on another healthcare of the elderly ward, there's been 45 contacts and 970 minutes of support. So that ward's been going really well. Next slide, please. As one of our patients on F21 said that there wasn't very much to do when they left the ward. So we've also been working on trails around the hospital. We've got a trail that goes outside the City Hospital and some arts trails that go around the campus inside Queen's Medical Centre and City Hospitals. And they're sort of launching this year. So the Sunshine Walk's launched around the outside of City Hospital, and the arts trails are launching in September. Last slide, please. And our next steps are to continue to recruit volunteers and to actually get to grips with our hand grip data, because we've got a lot of it, we just need to analyse it. Thank you very much.
Thank you very much, Jo. That's fantastic to hear from you. You sharing the project and the work that you're involved in, and obviously next steps. Really superb. So thank you very much. I'm going to move along quite quickly now to Paula, our final guest speaker from Notts Healthcare. So over to Paula. Thank you.
Hello everybody, lovely to see you all, and haven't we had some great presentations so far? I'm really impressed with all the data. Just as a little warning to you, I don't have any data. Okay, so I'm brand new in service. In fact, the physiotherapy service is brand new. I've been there since November. So the information that I'm giving you is what I've seen so far as I've been on the ward. So we're at really baby steps. So if any of you are out there even just thinking about starting, maybe I can give you some top tips. So I work across 2 hospitals, Sherwood Oaks and Highbury Hospital. I work 3 days a week, and I've got 8 to 9 wards to cover. So you can imagine we do a little and as often as we can. Next slide, please. So I just wanted to go through the psychological model that I use when I'm thinking about physical activity offers to different people, because we haven't really done this bit yet. And I really think about capability, opportunity and motivation for people to take part in physical activity. And when I'm thinking about the patients that I'm working with, some of them really have become so deconditioned outside in the community. They come into us when they are really, really poorly, psychologically and psychiatrically, they are unsafe to be kept at home. So they come into the community, but they may have been hoarding. They may have made no room to be in their houses or their homes to be able to walk about. So they've gradually got more and more deconditioned. They may be so anxious that actually they can't walk about, they can't go outside, they can't get shopping. So their opportunities for physical activity really, really reduced, and their capability of that, where they feel that they can do it, is really hampered by their mental health. So socially, their opportunity is down, and psychologically, it's really gone. So therefore, motivation is really is affected by this. But when we're thinking about physical activity, we have to cover all of those different all those different parts to be able to target the behaviour of increasing physical activity and for the patients to be moving more. Next slide, please. So some of the barriers that we come across, and in mental health, it's going to be slightly different to what you've seen already. I've told you about the staffing level. So the footwear, I think, is going to be across us all. But when you can't get out to shop, it's really difficult for you to go and get yourself some new shoes. And in fact, in the inpatient sec areas, some of our people aren't allowed shoelaces due to their suicidal ideation. So they aren't able to actually wear very much on their feet at all. So fear of moving, which is normal for lots of people, but fear generally of socialization is there. We've got lots of pain, and in fact one of the things recently is I've gone to see somebody about their back pain, and in the end ended up arranging for their toenails to be cut so that they could access their shoes, so that they could actually do some self-management to their back pain by walking more. So some of these people have also got many complex injuries or illnesses as well. They've got long-term pain, they've got anxiety, depression, all of these things impact. Some of them have hallucinations, telling them not to be moving, not to be doing this. And until those are settled down, it sometimes can be quite difficult to move people on to moving more, unless we do it in a very natural way. So with their chaotic thinking and their psychomotor symptoms, and psychomotor symptoms are symptoms that come physically in a body because of the psychiatric medication or the psychiatry that's going on there, so they're altered movement patterns. We just have to wait for the moment of readiness. That's a good point for me to get in there and talk about this. It's not just me that's doing this. We've got a live team there as well that are helping with the physical activity, and also a physical we've got a physical activity professional as well. So some of our medication induces symptoms, including obesity. It reduces mobility as well, just like you have on acute wards in physical health hospitals too. One of the other things we found out recently is that our PARQ, which is our physical activity readiness questionnaire for going in the gym, became a barrier. So that was becoming difficult for us. And also Section 17 leave, whether people are actually allowed off the ward or not, because sometimes people aren't allowed out their rooms or their ward because of their risks that they've got. And then, of course, ward staffing. It's always in there to free people up to come and do gym induction training. Next slide, please. So when we're thinking about capability, what we have to do is really understand the person, don't we? We have to know what's interested in them. If you ask me to go and do step aerobics, I'd be like, absolutely not, but put me on a dance floor. I'm there, I'm your woman, and I know quite a few therapists on here that join me. So there's no point in thinking, we have to find out what it is that they like to do and able to help them feel capable of what they can do as well. So if we think about their capability from a psychological and a physical point of view, do they feel physically able to take part in what you're offering, or do they feel that they are mentally able to get there? If we don't know the person, we don't know this. Next slide, please. So what is that right opportunity? And that goes back to that, what do we know the people? Do we know whether they like Zumba, whether they like physical, you know, whether they want to go to the gym, whether they want to walk? You know, was their favourite job washing up at home? What was it? Did they use the stairs at home? Are they used to doing that? Can we emulate that in the hospital? There's all sorts of different things, but it's about finding the right opportunity. And it's just making sure that you've got that tagged before you go offering something. Otherwise, we're wasting everybody's time here. So also then on the wards as well. Yes, thank you. So motivation's not easy. I can't tell you that it's easy. And you can imagine in the types of people that I'm working with, that motivation is even harder than you think. So we have to change that behaviour by making sure that we've got all those ducks lined up, as well as we can. Doesn't always work. Next slide, please. So some of the facilitators that we've got sports instructors, which is great, but they're part-time like me. We've got physios on site helping to barrier bust, mainly. That's what I tend to do. We've got a gym on site. We've got a gym observer training for staff to help them come up. We've just developed some generic warm-ups and cool downs, seated, supported standing and standing photo docs as well. Happy to share those if anybody wants those. Our PARQ's now going online. We're doing one-to-one work on the wards. We're doing group work on the wards, NDT discussions about the patients daily with the occupational therapists involved in the ward rounds. We've got activity coordinators who also get involved in the work that we're doing. We've got a live team who offer community gardening, going to Nottingham Forest, working in recreation centres with some of the people. We've got boxing coming in as well, all sorts of different things. Next slide, please. So what's the most important thing that I focus on when I'm thinking about physical activity for the teams? I'm really talking about building strength and improving balance. I don't worry too much about the cardiovascular state at the moment, because if I can get that strength up so that people can get up, walk around and move more, that's it, with regards to minimising sedentary time as well. So a lot of our patients just are so deconditioned, as I said at the very beginning. Some of them are overactive, and it goes from one extreme to another. And then we'll have people with eating disorders who may be seeking to take part in physical activity in an inappropriate way. We may also have people with dementia who need us to think about how we access physical activity for them around their job, for instance. Next slide, please, or their old job. So when we're thinking about our health risks and that metabolic difference that physical activity can make for everybody, when I talk about metabolic health to doctors, to nurses, I can see their ears pricking up. They don't sort of often, oh yeah, we need to get people active, we've got to, you know, get the CMO's guidelines going. No, I talk about something to the individual health worker that I'm working about that is going to interest them. If it's the OTs, we're going to help with their activities of daily living. If it's the activity coordinators, yes, that would be great. They'll be able to do the activities that you want. What is it that's first needed? Is it that strength to get up out of a chair? Is it that they need to increase their walking distance? Next slide, thank you. So I think, am I early? Flip.
You're on time, Paula.
Made it. Okay, so this is me. These are my contacts here. If anybody would like to be in touch, that would be great. If anybody else is out there in mental health land, even better, but happy to work across physical health as well.
Thank you very much, Paula, for sharing your journey, which is more towards the start with your team, but it's fantastic to hear, and hopefully you'll be updating us as you go along. Yeah, what matters to you versus what's the matter with you. I think that personalisation and that motivation comes in so much, doesn't it? We need to get to know our people, because what matters to one person doesn't matter to another. Brilliant. Thank you very much. So what I'm going to do now is hand over to Beth. We're going to be looking at the questions through the chat. And if anybody does think of a question now, then you can pop a question in. And we're going to have opportunity to ask a few questions to our expert panel and to, yeah, do some work all together. Thank you very much.
Excellent, fabulous. Thank you, everyone. That was really, really positive, interesting, lots of things to learn. So I'm just waiting for some questions. We've got one in the chat with regards to the model of human occupation. Do you know about that, Paula?
Yes, I do.
Can I direct that to you?
Yeah, absolutely. So I'm not an OT, so I can't specialise in this, but it helps us direct what it is that's and what that individual would need. And it's a great idea, I think, if you've got long-term mental health patients. The speed with which we work in acute services is really quite tricky. So they're fairly fast through us, not always, but sometimes. So yeah, but it's exactly the same thing. It's about finding out what it is that individual wants. And somebody's just asked me what a PAR-Q is. It's a physical activity readiness questionnaire.
Fabulous, excellent. There's lots of nice positive comments as well in the chat, which is really good. Let me just scroll for a few more. I think our wonderful presenters have done such a good job that there aren't actually that many questions. So what I'm going to do, if I can just ask our presenters to sum up in one sentence their take-home message for our community of practice today. Is that okay? Sorry, I'm sort of putting you on the spot here. If we go with James first, because you look ready, you're nodding.
You're never too unwell to get up and moving, Beth. I think that's my key thing. I think there's so many important things on patient outcomes, and yeah, you're never too unwell to get out of bed.
Lovely, that's great. There is a quick question for you, James. Could you talk about the process of evidencing your work?
Yeah, so at Kingsmill Hospital, what we're doing, we're also doing a similar QI project that I talked about that was done in Birmingham. So we've collected a lot of data before we're starting implementing our true early mobilisation intervention. So we've collected a lot of data on our first set where we haven't been providing that intervention because it's new to us. And then we've now started, we've put our guideline through after, taking all of the evidence that's out there to create a nice safety checklist. And we're going to collect our second set of data within the next few months. And then we're going to compare and have a look at the outcomes that it had.
Fabulous. Thank you very much. Joe, could I come to you next, please? And just say your one take-home message in a sentence.
So involve patients, get patients to tell you what they want and how to do it.
Lovely. Thank you very much. Jack and Aga are discussing their take-home message now. Would you like to share with us, guys?
Yeah, I guess from a surgical perspective, it's setting expectations early and getting patients to think about how they can make this change sustainable. It's not just a short-term fix. How are they going to get the most out of the surgery long-term through movement?
Excellent. And I can say actually from a medical perspective as well, from working on medical wards, our patients decondition in the first sort of 48 hours of their admission as well. So yeah, that goes for everyone. And Paula, I'm coming to you.
I just think I was quite impressed actually with the similarities that we've got between all the services around it, and whether it's mental health or physical health. I'd love to have more conversations with all the presenters about that.
Fabulous. So we've got a couple more minutes for questions and there's some popping through. Has anyone linked any of this to the reconditioning games? Joe, I think you did, didn't you? Yeah, go for it, Joe.
Yeah, so we entered the F21 work and also some other active hospitals work for medals. The way the medals worked, you kind of nominated yourself for which level of medal you wanted. So we nominated ourselves for silver medals, which we got. And we presented at some national webinars about the work we were doing as well. I co-presented with the PPG lead and they went really well. We had lots of interest in the Keep Moving sheet, which we would like to roll out in other areas. So if anyone's interested in the Keep Moving sheet, get in touch.
Oh, Paula's interested.
Yeah, you know where I am, Paula.
Has anyone else linked their work to the active reconditioning games at all? Any of our other speakers? No? Something for next year then. And we've got another question here from Kelly. Do we know if the idea of being more active while unwell in hospital is being promoted in medical wards? So I suppose, I mean, Joe, you mentioned that you're working on medical wards, and that is for our unwell patients as well as our sort of well patients, isn't it? Do you have, yes. Is Bramley ward, is that an acute ward?
So all 4 wards that I've worked with are acute wards. So we've got the alcoholic liver disease ward, we've got a renal ward, and we've got 2 HCOP wards. One of the HCOP wards is more of a medically fit ward, but the other's an acute ward. And so people have got a variety of medical conditions going on across those specialties. I suppose we acknowledge the fact that people who are medically unwell might have to be in bed for a bit longer. So that was why we included the bed exercises, because people might have a very long, they might have blood pressure problems, they might have some other condition that is preventing them from getting up, although obviously that is rare, but it does happen. And most of our patients that we see are acutely unwell, but they still engage nicely with the programme, and the volunteers are given training in how to kind of make sure that they know who they can work with and who they shouldn't be working with.
I suppose, Jack and Aggie, you have some medically unwell patients as well, despite it being sort of elective orthopaedics. You can still get poorly patients. What would your advice be in engaging those patients in physical activity while they are unwell?
I guess you can really scare people and put them off physical activity if, especially if they consider themselves to be unwell at that time. So I guess just gauging the level that they can do, whether it's just doing bed exercises or those sorts of things. But I think generally physical activity is promoted in however unwell the patient is.
Yeah, and I think quite often the doctors they encourage patients to be moving as well. So this is quite good from the team approach.
Yeah, and I really loved that about your presentation as well, about how you talked about the anaesthetists and how they changed their sort of drug cocktail and things to help the enhanced recovery programme. So yeah, involving the MDT, we all know it's everyone's business, don't we? And actually, if we're all singing from the same hymn sheet, everything becomes a lot easier when sort of motivating patients. Yeah, that's fab. Thank you. I am going to wrap this. Oh, sorry, Paula. Did you want to just add a final word?
Yeah, just very quickly, if it's any help to anybody, I talk in terms of movement snacks with my mental health patients as opposed to exercises. Sometimes they don't like the E word. So movement snacks are really useful. You can have a movement menu, a list of things that they like to do, so that you're sort of getting around the language barrier sometimes that's presented.
I like that. And it's food orientated as well, which I'm on board with. Lovely, that's fabulous. I'm going to wrap us up there. Thank you so much to everyone who joined us today. It's been fab to see so much brilliant engagement, and thank you so much to our wonderful speakers. I've really enjoyed listening to you. Loved seeing your faces, and I'm sure everyone feels exactly the same as me. In order to sort of continue to connect in between our webinars, we have a futures platform. We've been putting the link in the chat, and we've been putting a guide for how to join our futures platform. This is so we can keep the community of practice ongoing in between these wonderful webinars. And I think all I have to say is get out there, share the work, and share the messages that we've been saying here today. It's all our responsibility to continue sharing this. Have a lovely rest of your Thursday, and keep an eye out for the next webinar, because we'll be running them regularly.
Thank you, Beth. Thanks, everybody. So we're going to close the live webinar now. As we're closing, if you want to keep popping in the chat, if there's a pledge or a takeaway thing that you're going to focus on, it would be great to see that in the chat. We're going to end now, though, and thank you to all the speakers. Thank you to everybody who's joined us on the call. It's such an important priority around making movement the real priority, moving medicine, making movement the priority in our hospitals. Fantastic to hear from everyone. Thank you very much, and we'll close there. Thank you.
Thanks, bye.
Just wait and see if you want